Hello everyone, it's indeed a great honor and privilege to be presenting to you today. My name is Dennis Akeyo. I work for African Population and Health Research Center, and I'll be presenting on the topic, can improved access to hand washing infrastructure and soap change behavior? These are findings from a randomized control study in a refugee setting in Kenya. Introduction. Approximately 40% of the global population does not have access to hand washing facilities with soap and water. This is likely to be much higher in crisis-affected populations such as the refugee communities. As a result of this, these communities are at a heightened risk of morbidity and mortality associated with hygiene-related diseases such as diarrhea and respiratory infections. This burden can be substantially reduced through improved hygiene practices such as hand washing with soap. This study therefore aims to assess whether providing refugee populations with increased access to desirable and durable hand washing facilities will lead to increased hand washing behavior. The Jengu facility. This is a foot-operated hand washing facility developed by Arup, British Red Cross and London School of Hygiene and Tropical Medicine. It is long-lasting, desirable to use, and built locally with affordable and available materials. Specifically, it is built using robust steel that requires maintenance and is very long-lasting. The advantage it has is that its height can be adapted for children, adults, and people with disability. And to the objectives, we wanted to examine if providing Jengu facility results into increased and sustained rates of hand washing with soap over time. The study took place in the Dadaab Ifo Camp, a refugee camp located in the semi-arid town in Garissa County, Kenya. This was a randomized controlled study where participants were randomly assigned into either control or treatment groups. The compounds at Ifo camp are generally occupied by multiple households that have shared water and sanitation facilities. Therefore, we applied proportionate sampling in selecting the 300 households. Participating households were randomly allocated into the control and intervention groups through lottery. Of the 300 households, 150 were randomly assigned into the control group and 150 were assigned into the intervention group. Those in the intervention group received a Jengu hand washing facility, a jerrycan for water supply to the facility, and a regular supply of soap throughout the study period. The control households only received soap throughout the study period, and all the consenting households participated in a structured observation sessions which lasted 2 to 3 hours in a household. The primary outcome was the observed rates of hand washing with soap in critical hand washing times. So the baseline characteristics and features, majority, that is that 75% of the respondents were female, 59% were between 30 to 49 years, 62% did not have any formal education. With respect to the wash access indicators, majority of the respondents, that is 68%, took less than 1 hour to fetch water and return back to their households. With regards to the sanitation situation, most of the respondents used pit latrine, that is 86%. And finally, with regards to the hand washing facility used, a vast majority used mobile vessels, that is 98%. Deep dive to the key findings. Overall, there was a twofold increase in the observed hand washing with soap and water moments from baseline to endline. That is depicted by the graph in blue. In baseline, it was 358, and at endline, the moments of hand washing with soap and water was 597. When the results were further disaggregated by time points and groups, overall all households in the study showed increase in the hand washing moments across the study period, that is from baseline to endline. We observed an initial sharp increase in both groups, that is from baseline to 1 month post distribution. This was followed by a slight drop at endline, but generally there was an increase of hand washing with soap and water from baseline to endline. With regards to the specific critical hand washing moments before and after the intervention, we observed a significant increase in all the critical handwashing moments before and after the introduction of the intervention, but the most improved handwashing moments were after using the toilet, before eating, and before preparing food. The key question we may want to ask ourselves at this particular point are, what were the explanatory variables that might have led to the desired outcome, that is the increase in the hand washing with soap moments. In this study, we looked at the soap availability and the water availability. We observed an increase in soap availability near or next to the hand washing facility, and an increase in the number of hand washing moments observed. Our analysis therefore underscores the importance of having soap available for hand washing, as evidenced by our results that indicated significant association between soap availability and hand washing behavior. Also, with regards to the water availability, our findings highlighted that having water available at or near the hand washing location was associated with more hand washing moments on average. With regard to the changes in the reported diarrhea among children under 5 across the 3 time points, overall, there was a steady decline in the number of self-reported diarrheal cases across the 3 data points. To our 2 major conclusions for this study: availability of fixed and desirable hand washing facility with soap has potential to increase hand washing with soap and water behavior. And also, the availability of soap is important for sustained hand washing with soap behavior. With regards to the recommendations, availability of desirable and durable hand washing facility has the potential to increase hand washing with soap moments. Availability of soap and water are important and have the potential to increase hand washing with soap and water. With regards to future recommendations and for sustainable implementation, hand washing infrastructure, in this case Jengu and soap, should be complemented with behavior change interventions such as educational campaigns, social nudges, and this one will encourage long-term adherence to hand washing. Additionally, we recommend hygiene promotion should be integrated into the refugee health policies to ensure that these interventions become a core component of public health strategies in crisis-affected communities. And finally, with regards to the key highlights and implications for policy and practice, with regards to the accessibility of hygiene facilities for public health, we have seen that the availability of the fixed hand washing facilities with soap has the potential to increase hand washing, and in turn, this is critical in preventing the spread of disease in the emergency settings. With regards to building local community capacity and self-reliance, building capacity of community members to locally produce and repair the Jengu units where possible will be very good, because it will equip the community with the skills and it will lead to the sustainability and the use of the facility over time. With regards to the collaboration between diverse WASH stakeholders, WASH lead partners and UNHCR could champion the promotion of fixed hand washing facilities with water and soap within the humanitarian settings, ensuring basic hygiene needs are met in a sustainable manner. With regards to the hygiene promotion and targeting messaging, while having a dedicated facility it was accepted by the community and we saw that it increased the rates of hand washing, they still need to pair it with hygiene promotion and resource availability activities. This local community participation in the design and implementation of hygiene messaging to ensure cultural relevance and acceptability. Last but not least, I'd like to acknowledge the grant partners. The donor was ELRA. The lead partner was British Red Cross. Other partners included APHRC, IFRC, Arup, Kenya Red Cross, London School of Hygiene and Tropical Medicine, and finally the Uganda Red Cross. Thank you very much for listening to me, and I appreciate. I now welcome any question. Thank you.